Greetings, everyone. We are now in final session of day 2. It's great to be here with all of you, dear Zoom participants. We sincerely apologize for starting with a 10 minutes delay. We are not by any means going to delay the session. They are going to have their time, and we're going to delay a little bit further the closure of the session, so we have all the interactions and the knowledge that we're going to share here prepared. Also with online with us, we have already Kathy Sudlow joining us from Edinburgh, right? And David Charugi, which unfortunately could not be here with us and present as planned, but joining us from Switzerland. Good morning to you, and apologize for the waiting. Also online, our online host, Dr. Padma Roy, that is going to take some questions here. And without further ado, let me introduce Alex Newberry, the person in charge for research in the Dutch government. It's really a pleasure to have Alex taking his busy schedule to be here with us, hosting this wonderful session on trusted research environment. The floor is all yours, Alex.
Thank you, Paul. Thanks, everybody. So this session is on trusted research environments. We're going to have a bit of a panel discussion, but we're going to kick off with Professor Kathy Sudlow, who's online. It's my absolute pleasure to introduce Kathy. So Kathy is the director of the Usher Institute at Edinburgh University. She also was the author of the influential, quite easily named Sudlow Review that was last year, that was looking at data research, data infrastructure here in the UK. So I'm going to hand over to Kathy to start her presentation, and then we'll have a panel discussion afterwards. Thank you.
Thanks so much, Alex, and very sorry not to be with you. So I'm going to pull up a few slides just to help me, and I'll whiz through them as quickly as I can, just to do a little bit of scene setting. So can I just check, Alex, are those showing all right on the screen for everybody?
Yes, they are.
Oh, brilliant. Yes. Okay. Let's go then. So my opening statement really is about trusted research environment. So I'm not a technical person. I'm a medic and an epidemiologist, and I've turned into a population health data geek. But I don't run a TRE, although I have been involved in using them and in co-designing them and co-developing them. But in my view, to be useful, then the TREs are kind of pretty dependent on the sources of data that they hold. So they need to be populated with the sources of data that are needed for the research projects that they're supporting. They, of course, need to have the technical capabilities to securely hold, link, and enable remote access to the data for those research projects in a way that preserves the privacy of the data subjects. And there are many of you in the room who are technically far more au fait with all of those mechanisms than I am. They need, in this day and age, to support an increasingly broad range of analytic tools. And one of the barriers that analysts who have encountered is the range of tools that are available to them within some of the trusted research environments or secure data environments they work within. And then increasingly, they also need to be able to work interoperably with other TREs that hold similar or overlapping data, covering different geographies, different people, or possibly different data types. So that's really the kind of technical part of my little intro over, and I thought I would just give you a very rapid introduction to some of the work that I did over 23 and 24 leading up to the review that was published at the end of last year, which was essentially a review of the UK health data landscape, which was addressing a couple of things, was for UK government. So to map the linkable health data sets across all 4 nations of the UK, and then to outline some of the barriers to sharing data for public benefit whilst keeping it secure, and identify some of the solutions and make some recommendations as to how those might be overcome. The remit for that second part had a primary focus on England, but actually, as it turned out, and this will be unsurprising to many of you, the barriers were broadly similar across all 4 nations of the UK, and so in large part with the solutions, although of course there are some differences in the detail. And indeed the way things have gone subsequently is towards a set of UK-wide solutions, which I think is absolutely brilliant. So I wrote over 60,000 words in the review, and even the executive summary is kind of quite long, but the Office for Life Sciences managed really well to summarize the review on one slide. So it was basically to point out that we have many sources of health and care, and indeed health relevant data across the UK, with some fantastic initiatives. A few are shown on this slide. There are many others besides. We can't make the most of them because of poor interconnectivity between them, and linkage is absolutely critical, of course, because of the complex and inefficient systems for managing and accessing health data. And of course, there are some notable exceptions where that have really pushed the boundaries and done very well. Some of them delivered by colleagues in Wales. But all of this means that there's huge untapped potential. So our data can support our own care, the care of our friends and families, can inform an intelligent healthcare system that predicts and responds to demands. Data can drive the planning and delivery of equitable care, both regionally and nationally, and of course can support a thriving research and innovation landscape, but only if we have an ambitious and joined up data strategy. And you see on the right hand side of the slide some of the recommendations that I made as a result of the review that was conducted. So some of the key points I made in my review were that we use health data all the time to improve people's health and lives, that generally the public, patients and the public, support the use of their health data, not only to benefit themselves, but to benefit other people as well. A lot of what we ask them about, they sort of expect to be happening, but they do want to know what's happening, and they want there to be transparency around it. They want to know who's using their data for what and who is benefiting as a result. And all of those seem perfectly fair and reasonable things to be asking of the system. A key point from the review that many in this room, virtual and real, will be all too well aware of, but which politicians and policymakers are not always, is that the really transformational insights come when different sources of data and different types of data are linked together. So individual data sets are all well and good, and they can be extremely helpful, but it's the linkages that really adds the value. But of course, there are many obstacles and delays to be overcome. And often researchers, innovators, people in the NHS are waiting for weeks, months, or even years, or even give up in terms of being able to access the data that they want to use to be able to address questions that are in the public interest to know the answers to, because of our complex and inefficient systems. And as a result of that, many people across the UK are being let down. And so one of the points I made was that the UK's health data really needs to be seen as part of our critical national infrastructure. When I said that, I didn't actually know what that phrase meant, or I didn't know it had an official definition. But when I discovered what the official definition was, I still felt that it was a valid thing to be saying. So in terms of the health relevant data, that increasingly should and could be held within trusted research environments or secure data environments to enable its access and use for addressing a panoply of questions by a range of different types of researchers from across multiple disciplines. We have these nationally collated data sets that come from day-to-day activity in the National Health Service and are brought together at the level of each country and increasingly held and linked in secure data environments or trusted research environments, which now exist in each country of the UK. And Wales has done an amazing job with its SAIL Databank, not only in bringing that benefit to Wales that was in place prior to the pandemic, but in helping to build capability in other parts of the world as well, including Northern Ireland. And England was playing catch up during the pandemic, but is now in a much better place than it was. Arguably, it's got sort of more than one or several different offers potentially available to choose from, and some redundancy in the system, not always a bad thing. And then we have local and regional data. In Wales, I'm delighted that the route, the direction of travel is for Wales to operate as one, and for these more granular and detailed data assets like images, free text and laboratory data to be assembled on a national scale. And I'm quite convinced that that's the right thing to do, and I would encourage that to continue to happen. But England, being larger, has to some extent divvied itself up into regions for some of these granular data assets before they're surfaced nationally. There are, of course, many other data relevant to our health held in other administrative systems: census, social care data, income data, justice data, education data are a few examples of those. And then we have a whole bunch of other data that outside of these administrative systems, from personal monitoring, environmental data, and then importantly, data generated through the research community, usually with the direct consent of the participants in cohorts, be they large population-based ones or smaller clinical ones, or clinical trials that can operate at regional or entire national scale, or indeed internationally. So there are many examples of bringing together these different types of data sets successfully. I'm going to whiz through a few just to show you the types of things that can be done, and that started to become more and more possible during the pandemic, with the pandemic as a driver, but rightly should continue to be possible following the pandemic. And some of them, of course, were happening prior to the pandemic as well. But here's one which was linking data from across Scotland, England, and Wales, and then working across secure data environments to bring a national picture together of patterns of medicine prescribing and dispensing during the pandemic. And I won't go into the details. You can sort of see those patterns before your very eyes, and you can read in the pink text there of some of the consequences of this reduction in uptake of prescribed cardiovascular preventive drugs. Very similar exercises have been done for sodium valproate, looking at which is an anti-seizure medication. But in these types of exercises could and indeed should be used as a matter of routine for monitoring the uptake, safety, and adherence to guidelines for a multitude of medicines used across the UK. And then similarly, it's been possible to use similar approaches, in this case across all 4 nations of the UK, to look at vaccine uptake and indeed under-vaccination across all 4 nations of the UK and the consequences of that. And then more granular and detailed data has started to become possible to pull these types of data together as well at the scale of a country, for example, in Scotland of 5.5 million, where all the radiology images gathered across NHS Scotland have been made available for linkage to other sources of health data. And those go back in time, so that it gives the opportunity for longitudinal studies, for example, to look at the role of brain imaging in predicting dementia risk using advanced analytic techniques. And then something that I think is done particularly well in Wales, which is a demonstration to the rest of the UK, is the notion of linking data from across sectors to understand the wider determinants of health. Here's but one example, which has been facilitated through the SAIL Databank, which looks at the impact of school absence and exclusion on subsequent health outcomes in young people. There are many other examples. Many of those that we have in the UK come from Wales because of the success of the SAIL Databank in garnering trust from the health system, but from also other administrative sources of data, and the capability to link those together safely and enable researchers to access them, work with them, and generate these types of insights much more rapidly than in any other part of the UK. And then just a couple of examples of linking data from research studies, or the way in which research studies can be enhanced through linkages to routinely collected data from the health system and beyond. Here are 2 trials you will no doubt have come across: the recovery trial, which used centralized services from across all 4 nations of the UK to follow the health of its very large number of participants, to help ascertain outcomes at a scale that simply would not have been possible without these types of linkages. And then the NHS Gallery trial, which has used similar mechanisms to follow participants' health, but also to find the participants and enable them to be invited to take part in this study. And then we've got large population-based cohorts and indeed smaller clinical cohorts. I could have given many examples. UK Biobank is one of my favourite ones. You can see on this slide some of the examples that have relied on the data from participants taking part in UK Biobank to be linked to their routinely collected health and other records to enable studies like this to take part. The longitudinal linkage collaboration is doing exactly the same sort of exercise on behalf of 28 or 30 or so, somewhat smaller but collectively very large cohorts with millions of participants from across the UK, with the trusted research environment capability being provided by UK SERP, which of course you will know is a development from the SAIL Databank in Wales. So there are lots of examples of these types of successes. Unfortunately, there are many examples where it hasn't worked so well. So these examples tend to be exceptions, but we do have a lot of capability, and a lot of that capability has been demonstrated from Wales. So the recommendations from my review were around critical national infrastructure, investment in a national health data service, which could help to streamline and standardize a lot of the activity that is currently very fragmented and complex. But you'll note that my recommendation 5 is around a UK-wide system for standards and accreditation of secure data environments. And that might be something that we want to come on to discussing, because interoperability of standards as well as of data is incredibly important if this is going to work well for us across the 4 nations of the UK. The review, somewhat surprisingly to me, because I thought it would sit on a shelf and gather dust, has actually been received pretty well across the relevant government departments. It landed at a particular moment in time when the Wellcome Trust was taking a great interest in this area and starting to turn its attention towards the health data research capabilities in the UK. So as many of you know, this concept of the Health Data Research Service has been born through a partnership with significant funding from the Wellcome and UK government. And the Health Data Research Service is currently recruiting for its chair and CEO. Those will hopefully be in place but towards the end of this year, beginning of next, to help launch a government-owned company which will have a UK-wide remit with some core must-have whole population national data sets as the kind of fundamental pillars of its activities, and underpinned by this by a number of principles: the principle of public data for public benefit, secure data environments being a fundamental component to ensure privacy and security of individuals' data. And we've seen all major health research data-driven initiatives move towards providing access to research using secure data environments. UK Biobank, Our Future Health, newer Kids on the Block, the longitudinal linkage collaboration, as well as the large population-based trusted research environments. So we need those to be fully interoperable for this environment and ecosystem to be able to work optimally. So finally, just a few thoughts about Wales, because we're talking about Wales today. I think, and Alex and some of you have heard me mention this before, but one of the things I've been keen to say across all nations of the UK is that it's really important that we don't have unnecessary duplication of effort. Some redundancy within systems is helpful. Having single points of failure is not a great idea, but we can't afford to have multiple duplication of infrastructure. It's simply not affordable or sustainable in this day and age. In Wales, I think you've got the fantastic assets of the SAIL Databank and UK SERP to capitalise on, with your capabilities around the integration of GP data from primary care and cross-sectoral linkages as being essential ingredients that should be preserved and enhanced. And I think the One Wales approach to health, social care and cross-sectoral data and digital infrastructure is a very splendid one, which it makes every sense in the world to preserve. I'll stop there, and apologies if I've spoken a little over time. I hope that was helpful.
Great, thanks, Kathy. And I think you're going to stay on for our panel, Kathy, so there'll be an opportunity to ask Kathy questions as we open that. So I think we're going to have an opportunity just to introduce the other panel members now. So I've got Ashley in the room with me, and I think David is on the Zoom as well. Are we able to put him up on screen? Oh, perfect. Hi, David. So I was going to just give a chance for you, and Petra as well. Hi, Petra. So I was just going to give a chance for the other members of the panel to introduce themselves. I just thought I would pose each of you a question, just so if you can introduce yourselves and then just give an answer to the question, that would be a great start. So I'll start online. So in your view, what's the most important foundation for a trusted research environment to unlock sensitive data for research? So if I start with David.
Yes, good. So good afternoon, everyone. I'm Davide Chialuigi. I'm the director of the Personalized Health Informatics Group in Switzerland and the technical director of the Swiss Personalized Health Network Initiative in Switzerland. So to reply to your questions, based on our experience, actually, the main foundations that the main pillars of a trusted research environments are two. So one is the legal framework, so to say, so to be compliant with the set of rules that actually encompasses all the possible stakeholders, right? It's not like, so in Switzerland, this problem is particularly intense because of the federal organization. So our current TRE, which is called BSpace, is actually compliant with all the, let's say, different nuances of rules of all the federated hospitals. And this is one pillar, in my opinion. The other pillar is usability. So these compliancy, they need to be compliant with all the different rules of the stakeholders. Brings necessarily complexity into the user's experience. And then we need actually to take care so that this complexity is kept to a minimum, right?
Thanks, David. To Petra now.
Yes, hello everyone. Hello from Berlin, Germany. My name is Petra Ritter. I am a professor for brain simulation at the Charité University Hospital in Berlin. I'm also director for international affairs at the Charité, and I am leading a couple of large-scale European projects. So the largest one is the European Testing and Experimentation Facility for Health, AI and Robotics. And several of these European projects also involve the development and operation of trusted research environments. So what do I see as very important? Really, it is sovereignty and autonomy. Yeah, and this is how our trusted research environments are being developed. They are completely open source, which provides many advantages. So we are not running our health data processing on Microsoft or Amazon services, but use open source platforms that are self-developed and maintained and operated on premises. And there are several advantages of such open source approaches to software that is used for example, trusted research environments. First of all, sovereignty. There's a better control of data. Open source allows organizations and individuals to host and manage their data on their own infrastructure, and reduces reliance on proprietary cloud services, for example. Also, transparency, access to source code means that users can verify where and how their data is stored and processed and ensure compliance with the regulations that do apply. There are other advantages that I don't detail. I just want to mention them: security and privacy. We can go more in depth. But I think it's really important to mind sovereignty and autonomy and avoid dependence from large providers, especially also outside of our European region. So I'm from Germany, I'm European Union, you are UK. We have very similar legislations in terms of GDPR, for example. And I think it's important to collaborate. And the legislations reflect the values that we have together. And therefore, it's important to make sure that we have full control and that all the regulations that reflect our values can be maintained and put in force and in application.
Thanks, Petra. And finally, panel member Ashley in the room here.
So morning, everyone. So I'm Ash Egbar. I'm a professor of population data science research based at Swansea University. I'm also head of the user and data support services and research innovation at the SAIL Databank. So your question going back to it, so I build on a lot of the points already raised by the panel. I guess the additional ones I would add in are, so trust and transparency being key, both across a wide range of stakeholders, from the data owners you're trying to unlock the sensitive data from, but members of the public and other key stakeholders. And I guess the main other one that hasn't been mentioned yet is what I'd call incremental value and impact. So building on good examples to show why you want people to share the data with you. If you can't tell them why the data is potentially valuable and impactful to them, it makes it a lot harder to sell it as a good example as to why they should sell their data. And we heard examples from Em this morning and others. There's a lot of good examples out there across Wales and the UK. I think showing those examples then tries to sell that opportunity as to why they can have value back as a data owner to share their data owner with you.
Thanks, Ashley. So I've got a couple of questions up my sleeve if we need to, but I wanted the opportunity to open out to the audience. I can pick up questions here in the room. I'm assuming somebody is covering anything that is going to be online. Excellent. Anybody with
I'm
questions?
online. There are no questions online so far. If you would allow, I may have a question or two.
No problem. Any questions in the room before we go? No? Well, I've got one that I would pose to the panel. So given that we've got kind of expertise from across Europe here, and Petra, you mentioned about kind of some of the regulatory regime is common across the UK and Europe, but not all of it is that going to be the case. What do you think is sort of the contrast between the way that things are developing in Europe and the way they're developing in the UK, and what that mean about the opportunities? Maybe start with you, Petra.
Yeah, thank you very much. So actually, in many cases, UK is already providing very good blueprints for the rest of Europe, for the European Union, to my opinion. So we always look across the border to see how the UK is doing this. One example that I find very impressive and that I very often mention actually in these debates with, for example, members of the European Commission or other member states, is that we also need proficiency and literacy of the people to work with the regulation and to know how to work with the regulation. And this requires education and training. And I learned that in the UK, there's actually such a centralized training for health data proficiency and the registry where the passing of such trainings is certified and stored, and is a precondition for then accessing sensitive health data. And I think this is fantastic. I really would like to see this also in Europe, to give you just one example. And of course, I'm very keen to foster cross-border collaboration, interoperability, not only technical and semantic, but also legal interoperability, which requires the careful evaluation. And even if there are differences, there can be streamlined processes to take these differences into account, yeah, and that they then need to be provided to the society as blueprint solutions. And once this is available, it is very easy, even if there is some degree of heterogeneity, to follow these examples. Yeah.
Thanks, Petra. Anybody else on the panel want to offer a view?
Yeah, I have one question for Kathy. So, Kathy, your presentation is wonderful, but how can trusted research environment balance the need for the secure data access with interoperability across the UK? And what are the governance and partnerships are needed to link national NHS data sets with more granular, regional, and local health data?
Yeah, I mean, those are two quite chunky questions. So in terms of interoperability across the UK, even we even have some challenges within the UK on slightly different legislative frameworks across the four nations. So the challenges of like linking data internationally, say between the UK and Europe, and finding ways of safely sharing data for programs of work that need scale up, that also need to be addressed within countries. And I guess within some countries there are different laws across different parts of the federal systems and so on, so that every country has its own particular challenges. But so I think part of it is through the standardization of the sort of requirements of, well, what makes a trusted research environment a trusted research environment? What gives, and how can it be accredited? So I'm always reminded when talking about this of when I'm a neurologist and I used to work on looking after patients with stroke. When it became clear that stroke units improved the care of stroke patients and saved lives and improved outcomes, hospitals started opening up stroke units like there was no tomorrow. And sometimes they would just like create a stroke unit by slapping stroke unit label on the door of the ward that the stroke patients were looked after in, but nothing had actually changed. So that's clearly something that we really need to avoid. So I think it's quite, I think we are developing now, certainly in the UK, a set of standardized criteria that make a secure data environment or a trusted research environment that thing. And Ashley's probably a little more up to date than I am with exactly where those criteria have got to. I know that there are some trusted research environments that have sufficient agility and already have a lot of the accreditations that already exist in place, that they will very rapidly be able to acquire any new accreditations that are necessary. And there are others that are more early in their journey, that where it might be a bit more of a stretch. And I suspect that will be true of any country anywhere. But I think a shared set of standards and meanings as to what are the essential ingredients of a trusted research environment, both within countries, across the UK, for example, but also between countries, is going to be increasingly important. When it comes to different data types, I mean, in the UK, the main data types that are held securely and linked together and for which the access has been enabled at whole country level have been largely highly structured data, and they haven't included, by and large, more complex data types like images or free text. I think it's likely that those data types will need to be processed before they can then be provided within the very large scale environments, national environments, so that's likely to be more efficient. But I'd really welcome the comments of others. So, for example, imaging data, deriving values from the imaging data that can then be held, that can then be more readily moved around and held within secure data environments, or more readily shared through a range of different federation systems, will be more straightforward than doing it, than moving those entire granular data sets lock, stock and barrel around. But I'd be very interested in other people's comments on that. We know in Scotland it's been possible to do this with images at a population scale of 5.5 million. So at least that is possible. And the data quantities are not massive. They're not unmovable. So sometimes I think we sort of say we can't move data around because it's too big. I think actually it's more to do with, it's not actually necessarily too big, but sometimes it's not a secure thing to be doing, and it's not a necessary thing to be doing if there are other methods of querying data in situ and bringing analyses together in different ways. So maybe that's not quite an answer to your question, but it's a few musings on the general topic. Others, I'm sure, would like to contribute.
Thanks, Kathy.
Kathy.
So I was just going to pivot off that a little bit and just think about where next for trusted research environment. So you've talked a little bit there about, Kathy, about how we get more complex data sets in and linked. And we've heard already several times this morning about AI as being the future in this space. I just wondered, kind of from the panel's view, like where are we going next with trusted research environments that will continue to maintain their sort of their relevance and their ability to change the kind of the practices that we're looking at. Maybe I'll come to you, David, first.
So if I got properly, your question is about, which are the next steps we see as needed for a trusted research environment. So so my opinion, there is a lot of need for portability in the sense of, let's say, building, let's say, trusted research environments that can be deployed quite seamlessly, independently on the physical support. So they could be deployed on the cloud or on premises, or even in hybrid environment, which is, I see, the future in case we would like to perform in the TREs complex analysis, like genomics, for instance, right? It might consist in different steps, and each steps might require a different local environment. So I think portability is one pillar that should be, in my opinion, achieved in the future. Second pillar would be, in my opinion as well, a flexibility in the sense of achieving more, a better way of customizing these TREs for different kind of users.
Thanks, David. Anybody else want to have a view on that?
Can I add one question for David and Kathy and Petra?
Can I just add my opinion on what just has been asked? So the next steps for TREs, I was mentioning previously a good example where UK is leading, and we are looking at UK. There's another example where I think Europe already took good steps, so European Union. The Euro privacy certification. Yeah, we were just talking about the standards, norms, criteria for trusted research environments. And I think it was at the end of 2023 when the Euro privacy certification endorsed by the European Data Protection Board has come up. And since then, several certifiers have been accredited by the European Data Protection Board that can, on the one hand, provide support for the preparation for Euro privacy certification. On the other hand, then others can do the certification. And this Euro privacy certification has exactly this list, and the norms and standards. Some are international standards, like information security standards that are part of the Euro privacy certification, ISO 27001, for example. But there are additional criteria on top of this to ensure the privacy. So there is something in place that can be used, and I think this is very useful, and also was required as by European law. The GDPR foresees such type of certification. What is needed very much, I think, is a network of trusted research environments throughout Europe, UK, Switzerland, European Union, where data can be exchanged. We have talked about interoperability. A very important aspect here is that it would need a trusted digital identity provider for the citizens of the different states, the member states of the EU, but the UK and Switzerland, for example, as well, Norway, to be able to then really access these networks of trusted research environments. So there need to be agreed upon standards on trust levels, for example, for identity providers, in order to realize such a network of trusted research environments. And this network infrastructure is completely missing in the European Union. A nice blueprint coming from the UK is the UK Biobank. We also use data from the UK Biobank. Many researchers do. I know many. And there was a change, actually, over the course of when we used the data. Namely, they introduced these trusted research environments. And now the researchers are required to process the data in this trusted research environment provided by the UK Biobank. And this should be a common practice. I know that the health data access bodies in the European member states that should realize the European health data space that you might have heard about, they are struggling with providing such trusted research environments. And this is a big gap presently. And I think there we need to move forwards. And again, we can look at the UK and some solutions that you have already in place.
Thanks, Petra.
There is a general question to all of you panelists. from the future prevention of the diseases and also secondary use of the data for the TREs, what steps are needed to ensure that interoperability across countries include that includes diverse population data, so disease prevention and research is equitable as well as innovative.
Was that question for David?
This is for all the, yeah, please go ahead.
Yeah, I can bring my opinion in here. So I see the trusted research environment as a backbone for this to happen. There is another layer that is equally important if you want to federate data. So I think data federation across countries or across even data providers or stakeholders has two arms. So one is the, let's say, computational interoperability, if we want to call it like that, which is what we are now talking about. So trusted research environments, for instance, could foster data federation for the computational point of view. But the other arm, which is equally important, is the semantic layer. So how we translate data that are provided with different languages, so to say, from different stakeholders into a common language. And these are two arms that need to, be taken into account in parallel if we want to achieve what you are actually hoping to.
It's David, thank you.
Thanks. So I have a final question. I might start with Ashley. So we've talked, and Petra mentioned trust then. Ultimately, this is data about our citizens, about our patients, and how we kind of convince everybody or kind of continue to maintain that trust that the things that we're doing are responsible and are impactful. And I suppose my question, Ashley, is like, are we doing enough right now?
Good question. So I would say the direction of travel over the last 5-10 years, we're certainly doing a lot more now than maybe we did 10 years ago. I think that certainly we could always do more. Not to use buzzwords, but I guess for me, the key thing here is the word that's already been mentioned this morning. It's about co-production. So it's not a novelty just to include it because you have to. It has to be embedded from the start, really early at the design stage, throughout the process, and then in terms of interpretation and impact at the end. I'll use an analogy that, I host a team of data scientists. They're really good at using data. They don't understand what it means at the coalface from a service delivery point of view, from a lived experience point of view. So they can certainly support part of the process, but they can't know everything. And I guess this is where we really need to understand now, and coming back to the topics earlier around federation and interoperability, as we expand the types of work that we want to do, we have to recognize we need to do it in a multidisciplinary field, and bringing all of those expertise and voices into it has to be core to what we do.
Thanks. Anybody else have any views on kind of that public trust piece and how we kind of maintain and improve that?
Yeah,
Petra?
so if I may, our experience is if we talk to patients and also relatives of patients, they usually say, please use our data. We want to see the innovations that help our diseases. Yeah. And there were also surveys conducted actually systematically, and this was the same picture. Yeah, that the patients actually they quite trust and they want to see progress, and they are not so doubtful as it is always thought. The doubts comes more from the legal people. Yeah, and I think it's really important to show the society that there are trustworthy technical and organizational solutions in place, yeah, where, for example, also the patients can exert control over their data, access their data, and all this would really increase the trust. But the trust of the patients is not really the problem or the barrier, I would say.
Thanks, Petra. Is there any further questions that we have from the room? Oh, Emma, do you want this one?
Thanks very much. And, we work across the UK and obviously with a heck of a lot of different data owners. It's an observation of mine that data owners obviously want to be seen to be only giving access to data to the right people for the right projects. But it's an observation that their systems for making those decisions haven't really evolved in some cases from the days where you'd send out data on an encrypted CD, where you were entirely giving over that trust, to these days where it's portal access through a trusted research environment. How do we kind of give data owners confidence that modern systems and processes are in place, that data access procedures don't have to be as complex?
I'll look to Ashley to start.
Yeah, so it's a really important point. I guess I'll just come back to that word once again, trust and transparency. So when you're working with a new data owner who wants to share their data with you, I think where we found the greatest success is showing examples of where we've done it before, and in lots of cases putting them in contact with other data owners who also had the same questions they did, because the questions they have, they're not trying to be obstructive, they're just trying to manage their risk portfolio. And let's be honest, it's the Daily Mail article, other newspapers available, where you don't want your headline on the front where you've done something and you didn't do enough due diligence or you didn't put things in. So it just comes back to, it's a journey, and you have to go on it with the data owner and then ensure you've got trust and transparency around how you'll use the data, how it's stored, how it's accessed, and then it's that feedback loop. And in some cases, like we do with SAIL, it's allowing the data owner to be involved even more so in the process if they want to be. Some don't, some do. So it's providing the level of involvement they choose to have in terms of sharing their data.
Thanks, Ashley. I think Kathy, raise your hand, so you're looking to come in.
Just very briefly, yeah. So Emma, thank you. Great question. Nice to see you. I didn't know you were there, but I recognised your voice. I can only see the back of your head. So it's a really important question, and I think part of this is about changing the narrative. So thinking about the kind of the flip side. What happens if we don't use these data that are being collected and exist and that have the potential to address so many questions that are of relevance for public, patients and society? So, and to provide a kind of incentives framework that enables the custodians and the providers of data into trusted research environments, which is now, as you rightly say, where they're handled, where it is we do have a more safe and secure paradigm compared with before, but to provide them with incentives so that they get brownie points for making their data available. It's a rewarding thing for them to do, and I'm sure there are ways in which those incentives could be built in, but also by not kind of by government and other major central organisations absorbing some of the liability. I think this has been one of the issues in the UK with the provisioning of data from general practice, has been that individual practitioners in their small practices feel a sense of responsibility and liability for anything that goes wrong, which means that it's really hard for them to flip the narrative the other way and see the risks of not having the data used for public benefit. So if we can change the narrative and change the kind of liability, the ownership of the liability, and change the incentive frameworks, I think we would be in a better place. And otherwise, I agree with everything Ashley said.
Thanks, Kathy. And I think that point about the fear of data controllers is so important here. And as Petra said, it's not necessarily that the public themselves dislike the idea of these things, but it's kind of when you get into that sort of the bureaucracy and the liability issue of those data controllers. Anybody else would like to come in on that final point? Nope. Well, I think we'll wrap up there then. So I want to give my thanks and on behalf of everybody to Kathy, David, Petra, and to Ashley for a really good conversation. And I will hand back over to the next stage.
Thank you so much, Alex.
Bye-bye.
Thank you so much, everybody. I would ask for a special applause for Alex Newberry's fabulous moderation with 10 minutes delay. Always calm, keep calm, keep calm. And
everybody is looking for better healthcare solutions. What if AI could be the answer? AI in healthcare isn't just a buzzword, it's revolutionizing patient care. With AI, we can achieve more accurate diagnoses and personalized treatments tailored specifically to each patient. AI systems analyze vast amounts of medical data at lightning speed, identifying patterns that might be missed by human eyes. This means early detection of diseases, fewer errors, and more effective treatments. But the magic doesn't stop there. AI helps streamline administrative tasks, giving healthcare professionals more time to focus on what they do best, caring for patients. The result? Enhanced patient outcomes and improved quality of life. So whether it's predicting patient needs or making real-time decisions, AI is transforming healthcare, one patient at a time. Embrace the future with AI-driven healthcare solutions. Because better health outcomes start with better technology. Ready to take the leap? AI in healthcare, better diagnoses and treatments, making healthcare smarter, one innovation at a time.